Welcome, Scott, to the Danish homepage. We are here in Austin, Texas, at the International McKinsey Conference.
Yes.
And you have been treating a couple of shoulder patients at the stage,
Yes.
and they all ended up having the diagnosed derangement.
Yes.
And the rumor goes that you have found or developed 3 different patterns of derangement in the shoulder. And we Danes would like to hear what that's all about.
Okay, first thing I would like to say, I don't want to claim any sole credit for this. This is work that with colleagues, especially Dave Oliver, that we've start noticing that this, and I think we start realizing that these patterns existed probably at least 6 to 8 years ago now. And your mention of the patients having derangement, by far, this is the most common diagnosis that we see in the shoulder. I'm aware of the recent stuff that Stephen May put together and looking at percentages, and I know it's always dependent on who walks in your clinic, but it seems to us that the percentage of derangements that we see is much higher than is currently being reported. With respect to the shoulder, the patterns, and if we want to get into specifics here pretty quickly, the patterns all revolve around a patient presenting with limited or painful elevation, which would include either abduction and or flexion. And most typically we find a greater limitation of flexion than we do abduction. So if you have the patient that presents, and now we need to back up a little bit, we need to make sure we've ruled out the cervical spine as a source of the pain.
So what is the pattern in the history? What is the patient saying with pattern number 1?
Well, with pattern number 1, again, they have limited or painful elevation, but as far as the differentiation between...
So could that be inflection or out here?
Or abduction, yes.
So that's a 2-1 you're going for?
Yeah, that's all of these patterns start with that finding.
Okay.
The other thing, ruling out the cervical spine, we see very few, if any, shoulders actually have scapular pain.
Yes.
We make sure they don't have any local neck pain. They have no limitation of motion in the neck. But anyways, once we've determined it's the shoulder itself, and they have a limitation of forward flexion and or abduction, with or without, typically pain at end range. They can have pain during movement, but more typically end range pain. Then we assess internal rotation and extension. What we'll see there most commonly, and this is the first pattern, is that there is a limitation in motion in both of those. Often internal rotation is much more painful than extension, and when we see that, our first move, we would call that pattern 1, our first movement will be either internal rotation or extension. Mm-hmm. Typically we will look at the one that is most limited. With the exception of if somebody has such a severe limitation of internal rotation that they cannot even get the palm of their hand to midline. If they're over here, then even though that's a more severe limitation, we would look at extension first.
Okay.
And that pattern, the progression would be if we start with internal rotation, for instance, and we achieve improvement, but then it plateaus, we would then look at the others. So we would look at extension. If we looked at extension first and had improvement and then have a plateau of progress, then we would go to the internal rotation. The next progression would be a combination of internal rotation and extension. So it's a very nice pattern, and there's a very nice progression for it as well. Mm-hmm. The second pattern...
So to sum up, you have problem with elevating the arm, either flexion or abduction, and the finding is there's a limitation extension.
Yes.
And internal rotation.
Yes.
They have to be like that. There has to be this limitation.
Yes, they basically have the first 2 and either of the next 2, but typically they have both a limitation of internal rotation and
then you
extension.
talk. Yes.
Yes. And that by far is the most common presentation we see in the shoulder.
How many of the shoulders would you?
Well, I mean, it's statistics and incidence is difficult.
Your gut feeling.
My gut feeling. My gut feeling is if I see 10 shoulder derangements, that pattern probably exists in maybe 5 of them.
Okay.
So probably about half of them.
Yes.
Yeah, it's quite a common finding. Mm-hmm. And also interestingly, most of those patients will demonstrate significant external rotation weakness, that rapidly recovers when the derangement is reduced.
Okay.
So that's another clinical finding that you can use. The second pattern, and we'll get incidents out of the way, I think maybe out of 10 derangements, this is probably 2 or 3 of them. They again have a limitation of elevation, so that can be either abduction and or flexion. But when you examine internal rotation and extension, you find no loss of motion and no pain. If that is the presentation, then the reductive movement is horizontal adduction, making sure that the patient uses self-overpressure in order to produce an end range load. So they should be producing strain, and typically that's not a painful thing for them to do, but it'll have quite effect on their ability to elevate.
Yes. So it means you don't start with the patient self. You go patient overpressure immediately.
Yeah, pretty much, because if you try it yourself, it's very difficult to get to end range just using your own muscle power.
Just get the progression of force.
Yeah, and so we bring it right to the patient self overpressure, and we will even have them progress that to that of leaning against the wall and pushing into using their body to push in as a force progression. Now, the other thing I should mention is we do see sometimes a patient with pattern 1 with the limitation of internal rotation and or extension, and those 2 things clear, and they still whilst they may have improvement in their ability to elevate, it's not a full reduction. And at that point, we then transition to this horizontal adduction. Essentially, pattern 1 turns into pattern 2.
Yes.
Okay, so that's a very, very nice thing as well. The least common of these patterns, so to speak.
Oh, could I just ask about the first 2?
Sure.
In the history, are they presenting close to the same? It's the finding that's the most important stuff.
Well, yeah, I think pattern 1 in the history will describe more difficulty with lateral movements reaching behind, where the second pattern doesn't tend to say that as much, because if you think about it, they have good movement back there, so they won't recognize that as a problem as often as these people who say. But I think we should caution that just because a patient says they have difficulty with lateral movement, you should not immediately assume that the internal rotation or extension is the answer. You still have to go through the entire examination.
Yes.
Okay. The third pattern, and again, the gut feeling on incidence is this might be 1 out of 10 patients that you see with a classification of derangement is they have, limitation or painful elevation, again, either abduction or flexion. They also have a limitation or pain with extension and or internal rotation. So this is like pattern 1. However, when you go to internal rotation or extension, they do not improve, they actually worsen.
Okay.
And when you see that, then the reductive movement would be going to flexion with external rotation, the patient again using self-overpressure. So I will often have them kneel down and support the arm on a surface like a table, and so that they can make the passive, essentially they can make the flexion passive, and then use the other arm to produce the external rotation.
So this is a passive,
Yes, and it's all passive, and then if the progress starts to become slow or plateaus, the progression would be to start to move the arm into either horizontal adduction and perform the movement, or horizontal abduction with a strong bias towards the adduction. Very few of them will actually bring it out into horizontal abduction, much more commonly horizontal adduction.
Yes. So, so when you talk about those 3 patterns, so what they all have together, if you should meet a patient with shoulder pain and you think derangement, they need to have problems with flexion or abduction.
Correct, which is you think about it, most shoulder patients have
Oh
that
yes,
complaint.
I'll just,
Yes.
but that's
But that is certainly the starting point. The other thing I think that we need to make sure that people are aware of, we certainly see irreducible derangements in the shoulder.
yes,
The other thing is that despite this nice recipe of patterns, say for instance if it appears that you have a patient with pattern 1 and you don't get results, it does not mean you should give up at that point. You should continue to explore other
Yes.
movements. In my mind, the shoulder is one of the most fun joints to treat, just simply because the amount of different movements
Yeah.
that a patient presents with. I think the other thing that we do see, not extremely frequently, but certainly enough to make mention of, is that we will see a shoulder that presents as a derangement, and we reduce the derangement, but the patient is still having some complaint. And on re-examination, we find that they have an underlying contractile dysfunction. And in that case, then we need to go to resistive loading in order to, and of course that's a longer time frame of recovery, as it's described in the textbook. So we'll load them with resistance in order to provoke the pain. 3
so
times
like
a day.
treating dysfunction.
It's a straightforward. It is treatment of dysfunction. Yes.
So it's like in the spine, you can have it phase 3, like recovery of function. You can find that as well in the shoulder.
Yes, you do.
So if I could ask a few differences between between the spine and the shoulder derangements. Do you also see the centralization phenomena in the same way as the shoulder, for example?
Right, absolutely not. I think there's actually even danger in using the word centralization for the peripheral joints. But in any event, we do see a symptom response of localization, and I don't think it occurs at a very high rate, but it certainly occurs enough, again, that we need to recognize it. And the presentation is that the patient will come back and you start questioning and they say, well, I'm worse. Okay, I'm worse. And they say, well, now I have a more intense pain. It can be now constant, whereas before they might have had intermittent symptoms. But on closer questioning, they are actually describing a different pain. Where, for instance, on day 1, the patient's complaint may be a lateral shoulder pain, and when they return, they're talking about a pain that they often describe as very deep inside the joint.
So that's a localizing.
That's the localizing pain. And it can even be such that where the pain initially was a little bit more diffuse, it started in the front, went lateral or lateral, and actually even radiated down the shoulder a little bit. They'll come back and they'll use their fingertip, and it's there, and they're actually quite unhappy about it. But again, it's a different pain. Much like a centralizing pain in the back, the primary complaint may have been leg pain, but now they have very dominant back pain. But in any event, when you re-examine them, you'll find that their clinical presentation is much better.
Yes.
Their range of motion is better. Their movement loss has diminished. The symptoms associated with the movement loss is better. And again, just like initially, and even continuing to some extent, we don't know the full physiological mechanism of centralization. We certainly don't know the mechanism of localization. But what we really need to do is reassure the patient that is an okay change. In fact, I will tell the patient it's a positive change, that pain will typically only last for a few days. And I'm honest with them. I say we don't know what it is or why it occurs, but we do see it, and that it is typically a good sign, not a bad sign.
So that's a good start. I just also have to think about the time frame, and also what about the postural correction here in the, like we do postural correction in the lumbar spine. Where is the place for that in the shoulder?
Yes, the 4 stages: reduce, maintain, recover, function, prophylaxis, and postural correction is part of the maintenance of reduction. And honestly, in shoulders, we do see that you can actually rapidly re-derange these people with the opposite movement. For instance, somebody who is reducing with internal rotation can often be worsened very rapidly by the opposite movement. But we don't, I don't see it as nearly as big of a problem in the peripheral joints, especially the shoulder, as we do in the spine. You know, when people in the spine are vulnerable to flexion and they sit all day, that's quite a large problem. But often in the shoulder, we don't find the necessity to advise the patient, okay, you need to avoid this movement, simply because functionally we're not doing that
except sleeping.
Yeah, maybe sleep at night. And if it seems to become an issue on occasion, we'll address that. But in most cases, I don't think we need to.
How quickly is it reduced, and you can how quickly is it going before it's stable?
The initial reduction is often very rapid. In fact, you know, it's sometimes even more amazing than the spine. But I think what's different from the spine with the shoulder is that the spine, you can often get complete reduction in a few days or a few weeks or sometimes a little bit longer, where in the peripheral joints, the time frame that they will be needing to essentially reduce and maintain is quite long.
Yes.
So we will often start the patient with the reductive movement 5 to 6 times a day, about every 3 hours. And I often tell the patient, day one, it's very likely you'll be doing this movement for a minimum of 4 to 6 months. Now, that doesn't mean they'll be doing it 5 to 6 times a day for 4 to 6 months. As time goes on, they need to do it less often. And often within a month or two, they might be down to, say, once a day, maybe 3 times a week. And I don't know what that will be, but if you educate the patient will be able to determine it themselves, because if they decrease too much, the symptoms will start to return.
Yes.
But I find very few patients that can do the movement for, say, 2 or 3 weeks and be done with it. It's a more extended, but the good news is say they are doing it twice a day, that's enough to essentially keep the reduction maintained, but it does have a tendency to want to re-derange.
Okay, thank you so much, Scott. It was very good news and very interesting to hear this story or explanation for shoulder derangement.
Yes.
And I'm sure that the Danish members of the Institute is very happy. I'm happy.
I'm happy for this opportunity, and for the folks I know in Denmark.
Yeah,
hello and goodbye.
Thank you so much.
Okay.